Our next speaker is Dr. Nash Kalsotra, and he will tell us about DM in the liver and liver metabolism. Really cool study, and we are looking forward to your presentation.
Thank you so much. Let me start by thanking the Myotonic Dystrophy Foundation to invite me to talk about our recent work on the liver. So let me start by saying that our liver carries out a wide variety of biosynthetic, metabolic, and detoxifying functions. I think last I checked there are over 150 different functions that the liver carries out. And most of these functions are carried out by specific hepatocytes that are present at different places across the liver lobule. Now, the liver is made up of these repeating unit of hexagonal plates of hepatocytes, wherein this central vein occupies the middle of the hexagon. And then on the ends of this hexagon, at the 6 places, are the portal triads that comprise of portal vein, hepatic artery, and bile duct. And this unique vascular organization of the liver makes the microenvironment that is present near the portal triad to be very different from what is seen near the central vein. In fact, very simple processes in the liver, such as glycolysis, fatty acid synthesis, ammonia detoxification, drug metabolism, all of these are zonated where certain hepatocytes carry out specific functions here, whereas other hepatocytes here will carry out completely different sets of functions. So this architecture and zonation is important for the function of the liver. For instance, if you look at the periportal hepatocytes, they're going to receive a very different microenvironment because you have the blood that is coming from the gut that is bringing all the nutrients, along with them some toxins. But then you also have the hepatic artery that's bringing large amounts of oxygen and hormones. But as these nutrients are getting absorbed, the concentration of those nutrients, those toxins, those hormones, as well as the partial pressure of oxygen decreases. The hepatocytes here are seeing a very different microenvironment. You might be wondering, why should we study the liver for DM1? We have heard for the last couple of days that DM1 affects multiple tissues. These include skeletal muscle, cardiovascular, gastrointestinal, and central nervous systems. Over the last 10 years, it has become clear now that the liver is another organ that is affected in DM1. And almost 50% of the patients report abnormal liver behavior. That includes sometimes fatty liver phenotype, and in other cases, abnormal liver chemistry. And also, there is increased frequency of metabolic syndrome, and DM1 patients often shows high frequencies of glucose intolerance, as well as increased sensitivity to specific drugs, especially certain anesthetics and muscle relaxants. Now, despite the commonly observed GI disturbances, metabolic dysregulation, fatty liver, and increased sensitivity to drugs, the root cause of such dysfunctions in DM1 remains unclear. There's a possibility that the liver dysfunctions are secondary to the skeletal muscle pathology, or they occur due to gallbladder and bile duct dysmotility. But because DMPK and muscle-blind proteins are fairly well expressed in hepatocytes in the liver, it is also possible that the liver-specific dysfunctions in DM1 are actually hepatocyte intrinsic. So to test whether DM1 liver phenotypes were secondary to skeletal muscle pathology, we started by studying the livers of HSA-LR mice that express CTG repeats, 250 CTG repeats specifically in muscle tissues. But we did not see any evidence of hepatocellular injury or any fat accumulation in the livers of HSA-LR mice. Although when we performed GTT analysis, the HSA-LR mice showed significant glucose intolerance, which is another symptom of DM1, driven by perhaps insufficient insulin receptor signaling and also glucose uptake by the muscle. So these data suggest that the DM1-related dysfunctions in the liver might be originating in the DM1 liver itself. So to study the role of DM1 within the liver, we developed a new mouse model, which is tunable and liver-specific. We took advantage of two previous models. First, a liver-specific tetracycline-inducible model, which expresses a reverse tetracycline transactivator in under a hepatocyte-specific promoter. And the second model was the TRA960 repeat expressing mice obtained from Cooper Lab. And when we combine these two models, we have a model which induces DM1 within the hepatocytes when the mice are fed doxycycline. So we started this, the way we turn on the RNA toxicity in the liver is from birth. So the moms are eating doxycycline-containing food, so they're feeding the pups. And the doxycycline cross the breast-blood barrier, and the pups receive that, so they're turning on the repeats at birth. And then when we wean the animals, we switch them to doxycycline-containing diet, and we let them be expressing the repeats for about 3 months, and then we are looking at the liver health. So as is shown here, the liver-specific model recapitulates the major molecular features of DM1, which includes doxycycline-dependent repeat expression, formation of nuclear foci, sequestration of muscle-blind proteins on those RNA foci that are seen here, and misregulation of alternative splicing that can be reversed following doxycycline removal from the diet. So in a week, we can see that the splicing can go back to normal if we remove doxycycline and turn off the repeat expression. Satisfied that we were reproducing the molecular features of DM1 in the liver, we next determined the direct consequences of repeat RNA toxicity on the liver. We isolated hepatocytes from control and DM1 mice livers and performed deep RNA sequencing on those hepatocytes. And we noted widespread alternative splicing, polyadenylation, and mRNA abundance changes in DM1-afflicted hepatocytes. And this affected pathways involved in especially cytochromes P450-dependent metabolism, inflammation, innate immune responses, iron handling, protein phosphorylation, and cell adhesion processes. Now, in terms of phenotype, one major consequence of DM1 on the liver was increased susceptibility to damage and hepatocellular injury. Compared to controls, the livers of DM1 mice showed frequent pockets of inflammation, a biliary response, and some mild interstitial fibrosis. Along with the injury indicators, the livers of DM1 mice were significantly larger and heavier, showing spontaneous lipid accumulation, which can be seen by oil redo staining here. Importantly, both the injury and the fat accumulation were dependent on RNA toxicity, and they were completely reversed when we removed doxycycline from the diet, and by 2 weeks, we saw those symptoms could disappear. Another consequence of DM1 that I will be discussing today is its effects on drug metabolism. Now, as part of symptom management, DM1 patients are often prescribed analgesics for muscle and joint pain, and it has been seen that DM1 patients show increased sensitivity to some analgesics. Similarly, when undergoing surgery, complications often arise as DM1 patients are particularly sensitive to common anesthetics and muscle relaxants. So, to test if DM1 increases the liver's ability to metabolize drugs, we treated DM1 mice with zoxazolamine. And zoxazolamine is a muscle relaxant which, when administered to the mouse, paralyzes it. The animal is then placed upon its back, and we measure the time required for the mouse to settle. This gives us a measure of how long it takes for the mouse to clear zoxazolamine from its system. And we saw that DM1 mice took on average 50% longer than the control mice to clear zoxazolamine from their system and self-right. Now, like I said earlier, one of the major tasks of the liver is to do xenobiotic metabolism. And there are 3 phases of drug metabolism. There is the phase 1, where you oxidize the drug by using those cytochrome P450 enzymes. Then you can do conjugation, where you add some polar groups onto xenobiotics, including drugs, and then that helps to excrete those from the system. Now, drug-induced liver failure is responsible for 15% of all liver transplants every year. And also, there are about 200,000 cases of drug-induced liver injury a year. And finally, drug-induced liver injury is a barrier for approving new medicines, and frequently medicines that are approved are removed from the market when we learn about the hepatotoxicity of those medicines. To test whether DM1 liver is susceptible to drug-induced liver injury, we tested this common analgesic Tylenol, which contains acetaminophen as its active ingredient. It's also abbreviated as APAP. Now, APAP toxicity is long-studied model for drug-induced liver injury, and its mode of toxicity sort of relies on its conversion to this toxic metabolite NAPQI, which is generated from APAP by cytochrome P450 enzymes such as CYP3A11 and CYP2E1 in mice. And the injury is highly localized to this pericentral region of the liver lobule that I talked about in the beginning. So the cytochrome P450 enzymes are produced specifically near the hepatocytes, in the hepatocyte that are near the central vein. So the injury is very localized. Our results showed that the DM1 mice are actually showing much less necrosis than the control mice. And this is also evident at the H&E staining level. You can see this damage that happens because of the NAPQI near the central vein proximal hepatocytes is much less prevalent in the DM1 liver. Now, also then, when we give near lethal dose of acetaminophen to mice, DM1 mice have significantly higher survival rates than their littermate controls. Now, this may seem to you that this is a protective effect that is brought on by DM1, but it is important to note that these results indicate that DM1 afflicted liver is actually hampered in its ability to perform phase 1 drug metabolism. So because it is not producing that toxic metabolite, we're seeing less injury. But the other complication of that would be when you have a drug that you take, so it might not be getting metabolized at a rate where a normal individual metabolizes that drug. And the reason for that seems to be the overall decrease in many of these cytochrome P450 enzymes that include cytochrome P450-2E1, which is the main enzyme that makes NAPQI, various other dehydrogenases and transferases, including the sulfotransferase SUL2A1, which is normally involved in metabolism and excretion of commonly prescribed drugs. Now, DM1 is found most within North America and Europe, and diets from these countries can be high in sugar and fat content, especially in the United States. So we decided to test how poor diet choices might combine with DM1 to cause additional complications for the liver. So we fed mice a high-fat and high-sugar diet designed to mimic diets within the Western world. Specifically, this diet is loaded with increased levels of saturated fats and sucrose, which can present additional challenges to the liver and increase the chances of developing a fatty liver. So when looking at mice that are fed normal chow diet, it's already evident that DM1 mice show an increase in liver size, and also they have lighter color, indicating fat accumulation. Now, this effect is severely magnified on Western diet. Livers of control mice now, they are reaching the color and size of the DM1 mice that are fed normal chow diet. But if you look at the liver of DM1 mice that have been fed the Western diet, that show a dramatic fatty liver phenotype. And the microscopic analysis of fat accumulation showed that DM1 mice on Western diet tend to accumulate fat into these large macrosteatotic lipid droplets in comparison to the control animals. And this agrees with previous reports indicating a higher risk of fatty liver disease in DM1 patient population. Now, we went back and started looking at our RNA sequencing data, and there were a lot of changes in gene expression and splicing. So we spent some time to investigate how DM1 affects liver-specific lipid handling or metabolism, and we focused on DM1-related changes in splicing and abundance of transcripts that are linked to lipogenesis or lipid transport or fatty acid oxidation, and also metabolism-associated fatty liver disease. Now, of these, acetyl-CoA carboxylase particularly stood out to us. Now, ACC1 is the rate-limiting enzyme for the conversion of excess citrate into palmitate or fatty acids. And therefore, changes in the function or levels of ACC1 enzyme are going to directly lead to excess lipid production and potentially explain the steatosis that was noted in these animals. Interestingly, ACC1 regulation involves multiple phosphorylation clusters and a necessary dimerization event for it to function. So when ACC1 is phosphorylated, it's inactive. And this can be phosphorylated by various kinases, especially that measure the energy state of a cell. For example, AMPK, which is when the ATP levels are low in the cell, AMPK gets activated and will phosphorylate ACC1 So it would make sense that you don't want to make any fatty acids when you don't have much energy. So that's one way of keep the activity of ACC1 low is by phosphorylating it. What we found was that ACC1 is both misspliced and upregulated in DM1 mice livers. Now, the exon 28 that is highly included in DM1 mice livers is going to add 8 amino acids adjacent to this central phosphorylation cluster and is predicted to interfere with ACC1 phosphorylation by AMPK and protein kinase A. So again, that would mean that this protein will not get phosphorylated easily, and when it's not phosphorylated, it is active. And also the levels are high. And others have also shown that the inclusion of exon 28 results in decreased phosphorylation and increase in ACC1 activity. So to determine whether ACC1 missplicing contributes to DM1-related fatty liver disease, DM1 mice were treated with antisense oligonucleotides targeting the 5' splice site of ACC1 exon 28. And after the ASO treatment, you can see that the inclusion of exon 28 in DM1 mice livers dropped to almost 10%. But despite having this striking effect on ACC1 splicing, the ASO treatment showed only a modest sort of improvement in hepatic steatosis compared to control ASOs. We further investigated whether increase in ACC1 is required for the development of fatty liver phenotype in DM1 mice because we saw the levels of the enzyme were high. So we used an ACC1 inhibitor, and we orally administered this inhibitor twice daily to DM1 mice for 5 days, and then analyzed their liver health. And as is shown here, such a short-term inhibition of ACC1 activity led to a significant decrease in fat accumulation in DM1 afflicted livers, indicating to us that ACC1 upregulation perhaps drives the de novo lipogenesis in DM1. So in summary, what I've shown you today are our findings from the mouse model that recapitulate the effects of DM1 within the liver. Using this model, we found that just like other tissues, DM1 livers also experience global changes in mRNA processing and also splicing and mRNA abundance. We also showed that the repeat RNA-induced transcriptome defects lead to pathological consequences in the DM1 liver. And more importantly, the liver might contribute to many lifestyle and treatment complications that are faced when living with or treating DM1. There are 2 directions we would like to take for this project as we move forward. First, we need to recapitulate the findings from the mouse model in patient livers and in human cell culture models. Second, we would like to see if DM1 liver model may serve as a platform for early preclinical testing and development of DM1 therapeutics, because you don't need to target your drug modality towards a muscle or specific tissue. The liver is just going to take it, and you're going to see whether that improves foci formation, reverses the splicing misregulation, et cetera, and also may be relevant for some PK/PD studies for DM1. With that, I would like to thank Zach for spearheading this project. And so he took this project from start to completion. And he was also assisted by a new student, Fola Anya, who's sitting here in the audience, and also by a postdoc, Hani Bey, in the lab, who's now trying to take this project forward. Both of them have posters here, so if you haven't met them already, please go and check their posters out today. Fola is trying to find perhaps new defects in bioenergetics and mitochondrial dynamics that might be happening in various DM1 tissues. And Hani is now trying to understand the role of muscle-blind proteins in driving, and their sequestration in driving the liver pathology in DM1. With that, I would like to also thank Tom for sharing his TRE-960 mice with us, and also the funding agencies that have supported our work over the years. Thank you, and I'll be happy to take any questions.
We'll have time for one question.
That's amazing, actually. You talk about the other mechanism of myotonic dystrophy, not just lipogenesis, fatty acid oxidation, insulin-mediated PI3K pathway. Anyway, I have tons of questions, but I will limit it to only one question. So you mentioned this DM1 liver goes to steatohepatitis. And have you seen this liver goes under like a liver fibrosis, or have you seen increase of fibrosis genes in this DM1 liver?
Yes. So the question is about whether this mark produces any fibrosis. We see by 3 months of age mild interstitial fibrosis. The next thing we want to do is age these mice and see whether a 1-year-old DM1 liver is going to have widespread fibrosis or not. And then I'll be better able to answer that question, I think.
Let's give one more round of applause.